tumor BRCA status. So methodology: newly diagnosed ovarian cancers and newly diagnosed ovarian cancers at the end of their first line treatment, those are having either partial response or no evidence of disease or complete response after upfront or interval surgery or platinum based chemotherapy with at least 3 cycles of bevacizumab in primary setting and neoadjuvant setting at least 2 cycles. There were a total of 806 patients in 2:1 randomization with treatment arm receiving olaparib 300 milligram twice daily for 2 years and bevacizumab 15 mg per kg every 3 weekly for 15 months, including the doses given in the during the chemotherapy. And control arm received the placebo for 2 years and bevacizumab similar to the treatment arm. The inclusion and exclusion criteria. Inclusion criteria with stage 3 or 4 high-grade serous endometrioid, ovarian or fallopian tube, or primary peritoneal cancers with other epithelial non-serous ovarian cancers with germline contamination. And upfront or interval deworking surgery, including optimally and suboptimally deworked patients, completed first line of platinum-based chemotherapy, and she should receive minimum 6 cycles or maximum 9 cycles, and 3 cycles of bevacizumab or 2 cycles in IDS setting should be received before randomization, and no evidence of disease progression after first line chemotherapy, and performance status, ECOG status should be 0 or 1, or BRCA test report should be available. Exclusion criteria: non-epithelial ovarian cancers, low-grade serous cancers, and synchronous endometrial cancer. Malignancies in the last 5 years, they are still receiving any kind of some form of adjuvant treatment, and myelodysplastic syndromes, acute myeloid leukemia, previous radiotherapy within 6 weeks of starting the experimental drug, major surgeries within last 4 weeks, and bone marrow transplants. Previous treatment with PARP inhibitors, including olaparib, and several other exclusion criteria were mentioned in the protocol. So consort diagram, around 1,222 patients were enrolled, out of which 416 were excluded, 806 underwent randomization, 537 were in the experimental arm, 269 were in the control arm. During the primary analysis, 148 completed the treatment, 2 years per protocol, 53 completed 2 years per protocol in the control arm. So results of primary analysis, which was done at 59% of the data which were in March 2019, which showed with the median duration of follow-up of 22.9 months. The duration of investigator assessed progression-free survival was 22.1 months in olaparib group, with 16.6 months in the placebo group. Hazard ratio is 0.59. patient, there was no statistically significant treatment effect was seen. Overall survival was similar in the both control and experimental groups, only because of the distribution of HRD negative tumors in the both the groups. And in the patient with HRD negative tumors, you can see there is a statistically insignificant increase in the hazard in the treatment group, which class interval is crossing 1, and it is statistically not significant. And the side effects are equally distributed in both arms, and new primary malignancies were also reported in similar. Subgroup analysis of 5-year overall survival rate in HRD positive tumors in olaparib group with 65.5% compared to placebo group 48.2%, and BRCA mutated group median overall survival in the olaparib group was 75.2 months, and in the placebo group was 66.9 months. And HRD positive tumors except BRCA mutation, again there is a clear-cut benefit. Overall survival of 52 months, and in placebo not reached in the olaparib group, and the placebo group it is 51 months. HRD negative tumors, it is statistically insignificant. And these are the Kaplan-Meier curves showing the various subgroup analysis and the hazard ratios and treatment effect. Overall survival. This is the patient with HRD positive tumors. The A graph is HRD positive tumor including tumor BRCA mutation, and B is patient with only BRCA mutation. There is a gap at 60% data maturity. There is overall survival is 75.2 months. And this is HRD positive tumors.
Let's come back to the previous slide. What was this third graph where there's no difference?
Ma'am, this is the intention to treat analysis of overall population.
Okay.
Third graph is intention to treat analysis, and this is a patient with HRD positive tumors excluding BRCA mutation, and in the C, which there is a treatment effect of median OS is not reached in the olaparib group, and it's 52 months in the placebo group. And D is patient with HRD negative group, which there is at 60 months there is a statistically insignificant change. And E is progression-free survival in patients with HRD deficient HRD positive tumor population with huge difference in the treatment overall survival. Median this was the overall survival data of the 5-year survival. In 2022, there is a median PFS, which is also indicating benefit towards olaparib. There is intention to treat analysis. Median PFS was 22.9 months in olaparib group, and HRD positive 46.8 months. But again, in HRD negative and unknown group, it is 17, 16, 22 months, which is similar to the placebo group. 5-year PFS rate. And adverse events in both, especially in the in March 2019.
Your voice is not clear. Your voice
is not audible.
Yeah,
it's better.
No, go back to the previous slide where we just lost you. Go back.
This is the median progression-free survival, 5-year progression-free survival. That they have given tabulated. Intention to treat analysis in olaparib group is 22.9 months, and in placebo group is 16.6 months. And the subsequent beneficial effect is seen in both HRD positive tumors and BRCA positive tumors. But in HRD negative tumor or HRD unknown tumor, the median PFS is 17.3 months in olaparib, and in placebo it's 16 months with a hazard ratio of 0.9, which is almost like there is no beneficial PFS in these subgroups. And coming to the adverse events, which was done to of special interest, especially of special interest like MDA, MDS, AML, and pneumonitis and bronchiolitis, or any other primary malignancies, which is similar in both the placebo group and the experimental group in the each 5-year OS analysis and even analysis during the time of primary analysis. And coming to the most common adverse events at the end of 5-year analysis, which was fatigue in olaparib group was fatigue, nausea, and anemia. And most common and most common serious side effect was hypertension in olaparib group and olaparib group and anemia in the olaparib group, which was comparatively less in the placebo group. But when you fatal adverse events and fatal adverse events in it is less than 1%. It is less than 1%. Less than it is almost similar in the both groups, and even adverse effect of special interest. Like this is in the percentage forms 1%, 1%. And focusing on the current publication, this is current publication is the post-hoc analysis evaluating progression-free survival and time from first subsequent therapy and mature overall survival in patients classified by clinical risk and HRD status using Kaplan-Meier method. Approximately 50% of the populations are HRD positive in this trial. So in this analysis, in this post-hoc analysis, patients were categorized into high risk and low risk. High risk is stage 3 disease who had undergone upfront surgery and had a residual disease, or who had received neoadjuvant chemotherapy, or who has stage 4 disease. And low risk were patients with stage 3 disease who had undergone upfront primary debulking surgery, who had complete resection. The overall median follow-up was 61.7 months, and data cutoff was March 2022. It's a console diagram showing the stratification into high risk and low risk. In control arm, there are 399 high risk patients and 138. So in experimental arm, 399 high risk patients and 138 low risk patients, and in placebo arm, 196 high risk patients, 73 low risk patients. Baseline characteristics in both the arms were certified as high risk and high risk and low risk subgroup is similar in both the arms, and even the this age both arms. And coming to the results, this is a bevacizumab may have a potential to enhance cure in substantial proportion of HRD positive in low risk patients. A clinically meaningful overall survival benefit was seen with olaparib plus bevacizumab over bevacizumab alone in patients post tumor tested HRD positive, regardless of whether they were considered at high risk or low risk of disease progression, with particular benefit suggested in the lower risk patients. So this post-hoc analysis emphasizes on primary debulking and complete cytoreduction keys improved to PFS and OS, especially the low risk group, and it confirms that treatment outcomes can be optimized and should be guided by biomarker testing, and upfront use of olaparib and bevacizumab after chemotherapy should be started irrespective of high risk and low risk categories. So coming to the other trials which showed maintenance therapy in the primary setting, this is ICON 7 trial which showed post-hoc analysis showed PFS benefit irrespective of stage and residual disease, but OS benefit was only seen in high risk group. And this is GOG 218 trial which had 3 arms randomly assigned 3 arms which had first arm had only chemotherapy with placebo, and second arm had chemotherapy with bevacizumab and with placebo as maintenance, and the third arm has chemotherapy with plus bevacizumab maintenance. And with median follow-up 17.4 months, the PFS was 10.3, 11.2, and 14.1 months in control bevacizumab initiation and bevacizumab throughout. And ITT analysis of OS was at median follow-up of 1 or 2 months. Control arm had median OS of 41.1 months, and in bevacizumab concurrent plus maintenance arm had 43.4 months, and bevacizumab concurrent arm median was 40.8 months, which has no much difference. It doesn't make much difference in overall survival. And in stage 4 disease, the median was 42.8 months with hazard ratio of 0.75. This is a comparison of the trials which had maintenance therapy in the initial setting, that is GOG 1 trial ICON 7 as I discussed. Solo 1. Solo 1 is maintenance olaparib in patients with newly diagnosed advanced ovarian cancer. It's also phase 3 RCT, double blind RCT, and it involved the population with BRCA mutated advanced ovarian stage ovarian cancers, and the median duration of follow-up was 40.7 versus 41.2 months in the placebo group, and rate of freedom from investigator disease progression at 88% versus 51.1% at 1 year, 74% versus 35% at 2 years, and 53% versus 11% at 11 years, which clearly shows benefit of olaparib in the BRCA mutated advanced ovarian cancer as a maintenance therapy. And 5-year and 7-year overall survival rates were 73.1% and 67.7% respectively seen in Solo 1 patient receiving maintenance olaparib. So most common adverse events are similar to the Paula 1 group. Anemia is most common side effect, and AML, the incidence of AML in primary cancers are also seen. This is NCCN guideline showing
I have a query. Just come back to your Solo 1 final conclusion. Solo 1.
yes, ma'am.
Here. So you are saying this line is saying the rate of freedom from death at 3 years was 84% versus 80%. The hazard ratio for death was 0.95. The death is almost like 0.60 to 1.53. This is like insignificant. Was it like that? I'm not sure about it, because to my knowledge,
Yes,
the hazard ratio was 0.3. Solo 1 trial, because 70% reduction from risk of progression or dying of disease. But I mean, you must have checked it, obviously, when you've written here. But I mean, what about the other pattern, Lisa and Dr. Pandita? This is not much significant. What does it reflect?
Is there anything specific for this rate of freedom from death? Because that is 0.3, the hazard ratio. And also, I also know that, okay.
So
Risk reduction. Yeah, I don't know that what this means about rate of freedom from death.
So this is overall survival.
Statistical significance of this particular terminology.
Ma'am, this is overall survival data in 3 years.
Okay, we'll have to go into the details of that because, like, see, whenever you write these things, it just for all of you, it is very important whenever you.
So you want journal.
Yeah, whenever you present your journal, always read it that in depth that whatever you're writing, it has a meaning. You have to just understand that. Huh? Otherwise, it cannot be. Yeah.
It doesn't match the rest of the data. It is not statistically significant. All the other data is just.
So your voice is very.
Can you hear me?
So please come a little nearer.
Can you hear me now?
Yes, sir.
Yes, better.
Yes, I think we'll have to go back to this data because this doesn't match with the rest of the discussions we are having here. Thanks, Eva, for pointing it out. It was my attention as I was preparing this, but this doesn't match with the rest of the data.
Okay, so I'll cross check it.
From the changes.
Athena mono trial, which introduced rucaparib as first-line maintenance in high-grade high-grade ovarian cancer, stage 3, stage advanced high-grade serous ovarian cancers, who has having complete resection, permitted and respond to the first-line chemotherapy. In Athena mono trial, where the placebo was tested against the rucaparib monotherapy as a maintenance, and as of March 2023, in HRD positive, median PFS was 28.7, and in versus 11.3 months, and in intention to treat analysis, 28.2 months versus 9.2 months, and in HRD negative population was 12.1 months versus 9.1 months. So in Athena mono trial, there was benefit shown in the HRD negative population as well, using rucaparib as a maintenance. One more trial is Duo. The ongoing trial is Duo trial, which involves durvalumab, which uses durvalumab, that is PDL1 inhibitor, is immune checkpoint inhibitor. It has the study design is like this. It takes high grade advanced stage ovarian cancers, irrespective of BRCA mutations, and they were randomized into BRCA mutated and non-BRCA mutated. In non-BRCA mutated, there were 3 arms where platinum-based chemo. In first arm, there was platinum-based chemotherapy was given along with bevacizumab for 15 months with placebo as a maintenance. Durvalumab placebo and olaparib placebo, and arm 2 is 6 cycles of chemotherapy along with bevacizumab 50 mg per kg for 15 weeks, and durvalumab IV every 3 weekly for 15 weeks, and olaparib placebo. And arm 3 is they gave chemotherapy for 6 cycles and bevacizumab 15 milligram per kg 3 weekly for 15 weeks, durvalumab for 15 weeks 3 weekly 15 weeks, and olaparib BD for 24 months. This was the design of the trial, and this was also double-blind randomized phase 3 trial, and total in the BRCA mutated arm, they had received 6 cycles of chemotherapy with optional bevacizumab, but patient has received durvalumab for 15 months 3 weekly, and olaparib 24 months. So the outcome shows that median progression-free survival, which compared arm 3 versus arm 1. So there is a benefit of durvalumab, bevacizumab, and olaparib against arm 1, that is 24.2 months in intention to treat population. In HRD positive, it is 27.3 months, and even in HRD negative, arm 3 has shown benefit in PFS, that is 20.9 months, is hazard ratio of 0.68. So similarly, I've given the same things here. Progression-free survival was calculated in arm 3 versus arm 1, and numerical but not statistically significant PFS improvements also shown in arm 2 versus arm 1. Coming to the strengths of this study.
But the thing is, in the DOE trial, which you were saying, when you've added I mean, just come to your table. It's fine. Just
Yes.
come to your
Yes.
table. Next.
Table.
Next.
Okay.
Yeah, yeah. So in this, if you see that arm 1 versus arm 3, they have seen
Yes.
where they chemo plus bev versus chemo plus bev plus durva plus ola, right? So if you're giving these immunotherapy and both, so your outcomes are improving. So this, do you think it is enough? We need to also add the toxicity profile, the continuation rates, the duration for which the things are being given in this particular trial, right?
So,
That would be relevant, I think, for our understanding. That, I
I
mean,
could.
if you add more compounds, the toxicity profiles will be different, continuation rates will be different, and that would actually matter for translational clinical application of any study.
Ma'am, for this study, I could get only like few articles where they have given only this
Yeah,
data.
It's an ongoing study.
yeah.
This is an
So they have
ongoing
But
study.
presented
So
in the
yeah,
ASCO. I think they have presented in ASCO. I think we have the abstract presentation there. Is it?
yes,
You,
ma'am. Yes, ma'am.
yeah.
ASCO abstract.
So, but then this is very important for us to understand that yes, of course, whenever we add more things to it, it will definitely give us a benefit. HRD positive, HRD negative, we can see that there is no difference in the ITT versus this thing. HRD negative, HRD proficiency, HR deficiency per se, or BRCA
Yes.
mutation per se is definitely going to be beneficial for this population, as seen in arm 1 also. 19,
Yes.
17 months versus 23 months for this particular arm, even if you don't add anything, right? So once we
Yes.
add more things, what was the this, we are adding so many things. So this is
Toxicity.
whenever that the data comes, we have to understand all these important aspects too. Please proceed.
Uh, strength of my study is given. Paolo 1 was the first trial to have both PARP inhibitor maintenance therapy in the first line setting to include an active control arm which received bevacizumab. And Paolo, is generally representative of real world patients, and it has with a newly diagnosed advanced ovarian cancer as a patient selection was not restricted by surgical outcome and or biomarker status as compared to the previous other trials. And the limitations were the patients with no only the patients with no evidence of disease or clinical complete or partial response after standard first line treatment were included, and interpretation of the presented data are limited by post hoc analysis of the nature of the analysis, and there are certain subgroup analysis with in biomarker stratification there is small number of patients. Small number of patients. Thank you. Thank you.
So, what do you understand, Raja, that there were studies where in the maintenance setting only olaparib was used, as we saw,
Yes.
as we are very well presented at Tina Mono and Solo One trial, right?
Yes.
Then you had studies where bevacizumab maintenance was done, as you have presented GOG 218 and ICON trial, ICON 7 trial, right?
Yes. Yes.
So, and then adding both in the maintenance
Yes.
setting as it comes out in your presentation, right?
Yes, ma'am.
Right. So, can you tell us the numerical benefits which our patients are getting in each of these settings in the maintenance therapy? Just to summarize for the take home for the students.
Numerical benefits, ma'am.
Yeah, you can go back to your slides also. It's fine. I can
Oh,
understand it's very difficult to remember at times. It's fine.
okay. In Solo One trial, where the first I'll come to the bevacizumab and bevacizumab
Only
trials.
you are first telling us. So Raja is first telling us if we give only bevacizumab maintenance to our
Bevacizumab.
patients, so how much benefit in terms of numbers our patients are getting?
Okay, ma'am. In bevacizumab, uh, I have included only the primary analysis of ICON 7 trial where the median duration follow-up of 19 months. 19 months follow-up. 17 point uh, uh, 19 point median PFS of 19.4 months of 17.3 months in the standard therapy group and 19 months in the bevacizumab group with hazard ratio of 0.81. This was primary analysis in the ICON 7 trial. But post hoc analysis of this trial showed that overall there was no much overall survival benefit which was seen, but
Only
PFS
PFS
benefit
benefit. Yeah,
only
PFS
PFS
benefit.
benefit was seen in high risk group.
Yes. So this is very important that if you are giving bevacizumab to the patients where there was ascites, where there were suboptimal debulking, right? Subgroup was that
Yes, yes,
where the
yes, ma'am. Yes,
patients
ma'am.
got
Some,
significant benefit in PFS and
yes,
OS too. I think that particular group had OS benefit as well. But however, the group where the optimal debulking was done, I mean, in your language, low risk patients, as in this
yes,
particular trial, they have classified them into where they had only PFS benefit, right?
yes, ma'am. Coming to the GOG 218 trial, which had bevacizumab in both the initiation group and throughout group. So it showed in intention to treat analysis, the with the bevacizumab concurrent and plus maintenance group had median OS of 43.4 months, and in control arm it was 41.1 month, and in bevacizumab concurrent, which was given only during
Hello?
chemotherapy, it has 40.18 months. So it
क्या
has
कर पाई हूँ मैंने
showed
किसी और
slight
को बुला
benefit
रही है
of
थोड़ी अब
overall survival, not
जब
much,
आधा
in
काम
the
करके
concurrent
टाइम
plus
नहीं हुआ तो
maintenance arm,
मैंने पूरा
So
कर
now
and
दिया
this
median.
particular trial again, will not will this particular trial establish the importance of giving it concurrent plus maintenance. That's clear. So we currently we all know this is standard of care that whenever if you are giving bevacizumab, you should give it in concurrent plus maintenance setting. Simply concurrent or simply maintenance is not good, right?
Yes,
So we give it this way. So if we see that group, then there is 14.1 months PFS benefit, right? The
yes,
14.1 month, 3 months PFS benefit, right? Right. So the numerical figure comes out to be 14.1 month PFS, and OS will be almost 43.4 months, right?
yes, ma'am.
Right. Now let's see the next thing. Nice.
So this post-hoc analysis of this GOG 1218 and ICON 7 also showed that there was no OS or PFS benefit was seen in subgroup analysis of patients with BRCA mutation. This was given in NCCN guideline. I might not put it here. It was not shown any benefit in BRCA mutated patients.
Which group they know when you say that in mutated patients?
ICON 7 and GOG 218 post-hoc analysis showed there was no benefit of adding bevacizumab in BRCA mutated groups.
See, BRCA mutated group. What was the control? In which comparison are they saying this? This is important to understand. Was a control group that the general population where they were BRCA non-mutated and mutated both present, versus the group where they gave BRCA, they gave drug bevacizumab to both the groups. I mean, I'm not able to understand that part because, as
The
such, in my
control group was not clear.
So it's like the BRCA mutated group, there was no benefit of adding bevacizumab.
Yes,
What you're trying to say, right?
yes, ma'am. Yes.
In the risk stratification for giving bevacizumab in ICON 7 as well as in GOG 218 was clinical. The high risk groups which had high vulnerabilities, those were stratified. But when they tried to sub-analyze it according to the BRCA mutation, there was no advantage of adding bevacizumab in
BRCA mutated.
okay, that means that itself told us that itself give us the idea how to start maintenance therapy.
maintenance therapy.
Patients who are
It's a very good observation.
very mutated, the mutated patients, we should not give bevacizumab, won't be helpful. The mutated patients, it will be like PAV, right? And the patients which are not mutated, where bevacizumab holds some kind of role, right?
Yeah.
So that gives us some idea on this. Next, please. Yes.
Selection of cases are important.
Uh, in solo one trial, as I said, the median duration follow-up of 14.7 months, 40 months. The PFS benefit at first year was 88% versus 51%. 2 year it is 74% at 35%, and at fourth year it is 53% versus 11%. And in 5 year and 7 year overall survival rate were 73.1% and 67% respectively seen in solo one patients receiving maintenance olaparib, which showed benefit both in PFS setting and OS setting.
So this is particular group where we can't say that because it is a mutated patients. Solo
Yes,
one trial
only
included mutated patients. So this is to be noted here when we are comparing all these trials in the maintenance setting. that these are the mutated patients, so their survival outcomes will be different than the general population, which they used in ICON 7 or 218 trials, where they use a mixed group, where the BRCA mutation status was not analyzed for all the cases, right?
And the adverse events or side effect profile was similar. In most common side effects were anemia and anemia in the olaparib group, which was similarly seen in the Paula 1 trial also.
So yeah, so when we added now in your Paula one, when you added Bev plus olaparib, how much extra benefit your patients are getting when they are giving only BRCA, only this olaparib. When you add bevacizumab, then how much extra benefit your patients are getting? But that is the take home.
But ma'am, as per whatever the we have seen, gone through the data, here the final OS-PFS rate, especially in the placebo group where they have not received no difference in no benefit of PFS or OS compared to the olaparib group, even in the HRD negative tumor subpopulation. And even the adverse effects or side effects profile also is similar between the two groups, even after adding olaparib, there was no much side effects the patients noticed. There were no significant side effects patient noticed, but definitely there was no much benefit of bevacizumab alone.
Vomik, sir?
Yes, of course, we have been discussing the role of PARP inhibitors in the treatment of ovarian cancer for some years now. And to us, beyond any doubt that olaparib, rucaparib, or all the PARP inhibitors have made a huge difference in the way women are treated. And now we are identifying the subgroups where they are more effective and some women where they are not so effective. But what I find is very interesting in this post-hoc analysis is the way the groups were divided in high risk and low risk. And I was getting used to the fact that as surgeons we are like becoming scavengers. So every benefit is the credit of the better treatment was always given to the newer medicines, newer drugs, newer targeted treatments. And as surgeons, we're always in the backseat and observing what's happening. But this is an interesting article. This is an interesting article for us who are primarily surgeons to look at and look up the way the ovarian cancer is treated. And what it highlights is the low risk group are actually those who had upfront surgery and had a complete cytoreduction. And reiterating our old idea that the main benefit of treatment is actually in the surgery. Of course, these are the survival improves with adjuvant chemotherapy, better chemotherapy, targeted treatment, adding bevacizumab or not, or the PARP inhibitors. But the primary surgery, that is, I think, very, very important for all of us who are training in gynecology as surgeons, that the primary aim should be to achieve a complete cytoreduction. This is again highlighted in this because then the risk category becomes even lower. I mean, now the debate is still there that the complete cytoreduction was possible just because disease biology is different compared to the surgeon's credit that we have given maximum effort to remove all the disease. That's something we should know in the near future. But it is reiterating the fact that upfront surgery, primary surgery, reduce the disease to zero, and then all these medicines, the mutations in the germline, mutations in the tumor, the targeted treatments, all will fall in place. So I was quite relieved actually to see this study and the post-hoc analysis, where at least the surgical effort was given some value. And even if you overlap the two, the role of olaparib purple lines here. If you overlap those, you can see the lower risk where patients had complete cytoreduction far, far better compared to those where the cytoreduction was not completely achieved. So that's a very important highlight for us to take home message from this study, especially the post-hoc analysis.
Yeah, agreed, sir. And another thing, interestingly, they have included the PDS patients, the patients who underwent primary cytoreductive surgery into the low risk group. Rather, the neoadjuvant setting they have kept as a high risk group. So even this was a very different thing that other studies have never done, and they have reiterated the fact that, as always, surgeons say that the patients, it's always good to do by primary cytoreduction whenever it is possible. So they have kept those patients into low risk. And this question has been asked by Surya that can you please explain the criteria for high risk? So Raja, just please clearly tell them again the criteria for high risk.
Actually, this trial took the criteria from the ICON 7, but they modified in low risk category. High risk category, they categorized the patient with stage 3 disease who undergone PDS but had residual disease, or stage or patient who had taken NACT and underwent IDS, and the stage 4 disease patients are grouped under high risk. And in low risk patients are all the patients who underwent PDS with the complete cytoreduction.
Right. And the question is that difference between PFS and time for subsequent therapy. TFST, time for first subsequent therapy, and then we have something called as time to second subsequent therapy too, when you read into the maintenance trials.
Yes, ma'am. So there's no, ma'am, the meaning, maybe the one time, like initiation of the treatment after the recurrence, that is what it is. Time from randomization to first subsequent.
They have written this definition. So,
yes, ma'am, in the protocol they have written
they have taken this as an endpoint in patients who have, in the maintenance therapy trials, they don't take PFS, whereas they take it as TSST and TFST as an endpoint. Yeah.
And one more thing, ma'am, I forgot to mention in overall survival data, that in the post-hoc overall survival data was that this was not adjusted to the people after recurrence. There was no planning of crossover in the protocol. But once the recurrence has happened, the patient will subsequently received olaparib placebo groups. But this data was not adjusted at the time of analysis. Overall survival data analysis.
Probably continuing them without any medication thereafter will not be, kind of ethical. So it is important to understand.
Yeah, there was 50% of HRT positives were subsequently received PARP inhibitor, which was not analyzed. Yeah.
Because that won't be ethical to not give them treatment. Won't be right. So, and there's another question: what biomarker is required before adding bevacizumab? Can you answer, Raja?
Biomarkers, ma'am, before adding bevacizumab.
See, finding out a biomarker for starting bevacizumab has been investigated, and not clinically usable biomarker is not yet defined, but there are some biomarkers like anti-angiogenic factor, endothelin, CD31. These biomarkers have been correlated with, because it is an anti-angiogenic factor drug. So these have been mentioned, but I don't think we use it. And for that, clinical surrogate is, bulk of disease, ascites, suboptimal debulking. These are the surrogate clinical markers which you can use in your clinical practice to start bevacizumab. But like for OLA, you have HR or you have BRCA. So these kind of a biomarker for bevacizumab is not yet in practice, to my knowledge. Sir, if you would like to add something.
Yes. Now the current trend in practice is that if you have a stage 4 disease, or if you have a residual disease after surgery, then there could be a role of adding bevacizumab, but at the same time you have to counsel your patients that it's not going to add to your overall survival. It's just going to delay the recurrence of the disease by about a few months. At the same time, you have the risk of some serious complications. I mean, although not, if you look at the percentage-wise, it's not very common, but spontaneous intestinal perforation is a dreaded complication, and patients undergo misery after this. Just having a treatment and then ending up with some serious complications, like things like myelodepression, anemia, and all these are correctable. But the deadly complication of intestinal perforation, to attain a few months progression-free benefit, sometimes is difficult to justify. But again, you have to take things into perspective, discuss with your patients, inform them that these are the benefits and these are the risks. And I think it's better to leave it to the patient's choice when they're agreeable to accept those small risks associated with the use of bevacizumab. Then yes, it can be given. Again, only those where there was a significant amount of residual disease, stage 4 disease, where there is extra abdominal disease, like in the thorax, in the neck. So these are the cases where you can, but we don't have a biomarker to say these are the ones which can be, who can benefit from this.
Another question is, in DUO trial, durvalumab is added on what? I mean, he's basically wanting to know, did they use any kind of biomarker? I mean, there's a CPS score or something, PDL1 or P1, to start immunotherapy in these patients in COPD. I
Not that of
yeah.
describe much surely. I did not go through the protocol of no trial.
So you have to go through the protocol actually for the DUO trial. What did they use? Because whatever the CPS score and all, they were using.
We got muted.
Sorry. So I was saying that for cervix they use CPS score. If you go back into Empower trial or other trial like Gala trial, they had used these scores for analysis, for assessing the benefits, and because they found that there was a group of patients where CPS score which was significant, was they, I think less, I keep on forgetting that, more than one or less than one. So they give the benefit was more in that group. But for ovary, because ovary behaves differently, so we cannot extrapolate that. So we have to go back and check the protocol, as Raja is saying, that we have to go back and check the protocol whether they used it or not, or they used it for the whole group, and then they would do a subgroup analysis whether the patients who had this versus those who did not have this. So usually the trials have done that.
So as I understood from the abstract only is that they were not tested for PDL1, and as I understand that the incidence of PDL1 positivity is very low in ovarian cancer patients. So I mean, we'll have to read
Exactly.
that article before we actually.
Yes, because ovarian tumor microenvironment is very complicated as compared to if you go into cervix or you go into ovary. They're very different receptors. You have lot of things inside the ovarian microenvironment, inside the angiogenesis, the factors, and all those inhibitors. So those things are really predominant, and that is why immunotherapy is not yet an established care in ovarian cancer. We have to first tackle the microenvironment, and then only we can ensure that the receptors, the blocking those receptors is going to work. So that way.
But it was a great discussion